Welcome to this online resource for the Shoulder Pain Advisory Clinic. The main aim of this resource is to try and help you understand what can cause shoulder pain, the possible impact it might have on your health and function, and then what we can do to try and help manage and improve your symptoms. So if we start by having a look at your shoulder joint, you can see a picture of it in the top left there. When we refer to your shoulder joint, we'll refer to the ball and socket joint. So you can see the ball that sits on the edge of your humerus, which is your arm bone, that fits into the socket on your scapula, which is your shoulder blade. Now you can see that the ball's an awful lot bigger than the socket itself, so it looks a bit like a golf ball sat on a tee. Now the reason that the ball is so much bigger than the socket is because the shoulder joint is one of the most mobile joints in your body. The reason for this is to enable you to position your hand in space to do the tasks that we need to do on a day-to-day basis. Now, because the shoulder joint is so mobile, it requires some support from the structures that surround it, and in the bottom left there you can see that it has a joint capsule that sits around the joint, but it also has some ligaments that sit around it that give it some stability as well. We also get some support from the rotator cuff. Now, the rotator cuff is a group of 4 muscles and their tendons that sit around the shoulder joint that not only give it some support, but are also responsible for the movement of your joint. Now often when we get shoulder pain, it's these structures that either become overloaded or irritated in some way, and they can then become a source of pain. To put shoulder pain in perspective, we know that it's fairly common in the UK, with 14% of us getting shoulder pain at some point in our lives. And if we consider the depth and breadth of conditions that GPs cover, we know that 2 to 3 out of every 100 appointments with a GP is someone seeking help or advice about shoulder pain, so we know that it's fairly common. We know that it can have an impact on your quality of life and can have an impact on your ability to care for family and friends and place strain on those relationships. Broadly speaking, we try and categorise shoulder pain into smaller groups. The reason we do this is because the conditions that fall into those groups are treated in a very similar way. The 2 groups that I'll go over here are what we classify as the painful group and the stiff group. What I want to emphasise here is we're not saying that the stiff group don't have shoulder pain, because we know that they do. The difference tends to be that those in the stiff group have pain with a movement restriction and a feeling of stiffness, and those in the painful group have shoulder pain without that movement restriction. So if we look at conditions that fall into the stiff group and what can cause a stiff and painful shoulder, we're looking at generally a frozen shoulder that most people have heard of, osteoarthritis, and sometimes we just get stiff and tight muscles in response to pain or injury. Now, a frozen shoulder is a tightening or a stiffening of the structures that surround the joint with an element of muscle guarding. We don't know exactly why it happens, but we know that it's often overdiagnosed because it only affects roughly 1% of the general population. Having said that, we know that you're 5 times more likely to get a frozen shoulder if you're diabetic, and we know that there's an increased association and likelihood of it being a frozen shoulder if you've got thyroid problems, if you've had trauma to that area, if you've had surgery around your chest and your neck, for example. Now, this commonly affects people between the ages of 40 and 60, and what people tell us is that you usually go through 3 phases of symptoms. Now, in the first stage, the painful stage, we don't always have that movement restriction, we often just have severe pain, but over time you'll start to lose some of the movement and the shoulder joint will start to feel stiff. We'll then enter what we call a stiff stage, where the pain continues, but the movement restriction or the feeling of stiffness tends to be the main problem here. And then we'll enter finally a thawing stage, where the pain starts to get better and that movement gradually comes back. Now, what I want to emphasise here is not every stiff shoulder is a true frozen shoulder, so some people might recognise those phases, whereas others might not. And generally with a true frozen shoulder, you're looking at up to 18 months to go through those 3 phases, but stiff shoulders can improve over varying time frames and might not have those above phases. Sometimes in response to pain or an injury, we can just get stiff and tight muscles. So what this looks like is you get that protective muscle spasm or muscle guarding that we know can mimic a frozen shoulder. And this can be a cause of that progressive loss of shoulder movement and that shoulder pain as well. These are the ones that tend to get better more quickly, and they tend not to have those phases we've just talked about for a frozen shoulder. The reason we know it can mimic a frozen shoulder is if we look at what a frozen shoulder is, with those stiffening and tightening of those structures that are around the joint, when they study this and they put people to sleep, the shoulder joint is really stiff. Okay, for some people, when they put them to sleep and they give them quite a powerful muscle relaxant, that movement suddenly comes back. So we know that it's not necessarily that true frozen shoulder with the joint being stiff, but that there's that protective element of muscle guarding that's stopping the joint from moving. Osteoarthritis is a condition that most people have heard of. It more commonly affects the hands, the knee and the hip, and often is described as a wear and tear process, but more accurately we should probably describe it as a wear and repair process. The reason for this is your body is replacing all of the cells that it has all of the time, but when it replaces those cells it doesn't give you an exact copy, it gives you a slightly aged version. So what that looks like in the joint is you see a roughening of the edges of the bone and a reduction in the joint space. Now this happens in response to lots of factors, including your genetics and hereditary factors, lifestyle factors such as smoking and obesity, but other factors such as if you had any trauma to the area, any previous surgery, infections, or any other underlying conditions. Now, because this is quite a normal age-related process, we know that it more commonly affects people over the ages of 50, but actually that increases in prevalence the older we get. So you're more likely to have it in your 70s than you are your 50s. And we know that you're more likely to get it earlier in life if you've broken your arm before, for example, or if you've dislocated your shoulder. Now, this is quite a normal age-related change, and this is happening over many years. Often when we've had shoulder pain, it's only for several weeks or several months, and rather than the structure necessarily being the problem, we've flared the joint up and made it become painful. So most people with this will see an improvement in the symptoms without any change to the structure, and that improvement may happen over varying time frames, but most people get better with physiotherapy with the aim of trying to improve your movement and settle your pain down. Symptoms we often get with a stiff shoulder is you often get pain into your upper arm. Sometimes it'll come below your elbow and up towards your neck, and you'll find it difficult to put clothes on and off, to shower, to style your hair, and you might get pain when putting your hand behind your back, and also get some pain when you're lying on your shoulder. Now, these symptoms will look familiar to those with painful shoulders, so those without the movement restriction. The key difference in the symptoms tends to be that feeling of stiffness, the restricted movement, and the loss of movement. How long stiff shoulders take to get better varies, but we know that most people, pain will settle with time and that movement gradually comes back. However, they can take up to 2 years for that movement to return. Most get better in much shorter timescales than that, but that's often the timescale we can be looking at. The way that we diagnose a stiff shoulder is we have a look at the history of your problem, so we listen to your story, and then we have a look at other factors such as your age. Have you had any injury to it? Are you diabetic? Do you have any thyroid problems? And then when we have a look at your movement, when a joint gets stiff, it gets stiff in a very particular way. So you'll lose the ability to rotate your arm. So as you can see in the picture, when you're keeping your arm by your side, you'll struggle to take that arm out to the side or struggle to reach behind your back. So that's what we call a capsular pattern. How we treat stiff shoulders includes informing you and giving you lots of information about conditions that can cause a stiff shoulder, by giving you advice on how we can modify your symptoms and activities to try and help settle your pain, taking appropriate pain relief to try and help manage your symptoms, and then physiotherapy with the aim of trying to improve your movement and settle your pain down. Now that's primarily exercise based, and we know that for most people that's all they'll need to get a good improvement in the symptoms. In some cases they will consider a steroid injection to help settle your pain down, but that's only for certain people that meet certain criteria. And sometimes further down the line, if you've not responded to any other measures, including physiotherapy, injections, and you've still got really severe or functional limitations and movement restriction, then sometimes they can consider surgical options. But like I say, those are reserved for those with really severe functional limitations that haven't responded to the first line measures. Moving on to the painful shoulder. Now, the painful shoulder we most often think is caused by tendon pain, and it's the tendon that's giving you the pain. And this is often caused by factors that alter your shoulder tendon's ability to do the things that it needs to do on a day-to-day basis. Now, this either happens gradually over time, where the things that we've done day-to-day, so that repetitive strain has overloaded your shoulder joint, or from there we can sometimes get a sudden increase in load that then gives you shoulder pain. So usually people tell us they've either carried a suitcase through the airport or they've done something that they're not used to doing, such as helping someone move house or some heavy lifting that they've not done before, and since then they've had the shoulder pain. Like I said previously, we mainly think that it's the tendon that gives you the pain, and that it's a change in your tendon's fitness that starts it to become overloaded, and once that tendon's become overloaded it can become inflamed, and once it's inflamed it can become a source of pain. Once that's happened, other structures around your shoulder joint can also become a source of pain. Okay. Things that will influence your shoulder tendon's fitness and the load that we place on that tendon are the things that we do on a day-to-day basis, how difficult and how strenuous those activities are. So something that's really heavy is going to be a lot more demanding than something that's quite light, but equally if you're doing quite light tasks that are over a prolonged period of time, that's still placing quite a lot of demand on your shoulder tendon. Occupational factors are a big one because we know that we all need to try and earn a living, and often these can be quite difficult ones to manage if it's your job that you're doing the same things over and over again that's giving you that overload on that tendon. Age-related change is another one because we know as we get older the tendon loses some of that elasticity and loses some of that fitness with time, and that doesn't just happen for people over 50 and above. This starts to happen from your early 30s. Other things that will influence how fit and how strong your tendon is and what it can do day to day is how much rest or how much recovery time does it get to recover from those activities that you've been doing with it, and actually how much strength did we have at the beginning. Now, because we mainly think it's the tendon that gives you the pain in this group, we've moved towards a term called rotator cuff related shoulder pain, but I'm aware that some people might have been told that they've got impingement, subacromial shoulder pain, or bursitis. They're all effectively the same thing here, we've just moved towards a term called rotator cuff related shoulder pain, and you might be wondering if they're all the same thing, why do we have so many different names for them? The reason for this is, as we've researched things over the years, our understanding of those conditions have changed, and then they've tried to change the name to reflect our current understanding of things. So, for example, impingement, that I'll cover in more depth in a second, comes from a model of us squashing or trapping the tendons as we lift our arm, and then they started to realise, well, actually, not everyone fits into that group, so we'll move towards a term such as subacromial shoulder pain that just means you've got pain in and around your shoulder without a movement restriction, and you fit with certain signs and symptoms. The term impingement comes from, if you look at the shoulder joint in the top left there, in the space just above the ball and underneath the acromion, that subacromial space, we have tendons. And this space changes in shape and size as you lift your arm. Now, they used to think that as you lifted this arm up, we trapped the tendon in that space and it became impinged. We now know that this isn't necessarily an accurate model. One of the reasons we know this is that surgical procedures that make this space bigger aren't any better at relieving pain than natural healing over time or comparison to people that haven't had anything done to it. And actually sometimes we get bony spurs that sits under the acromioclavicular joint, and we can see tears in the tendon that they used to think was caused by lifting your arm up and it being squashed into this tendon. But actually, if you look a little bit deeper, we know that often we get tears on the side away from that bone. So it's not necessarily the bone pressing into the tendon that's giving you that injury. So we know now that not everyone fits into that group, and it's not necessarily an accurate model. Symptoms people often get with a painful shoulder is, again, they often get pain in the upper arm that refers sometimes below the elbow and can come up towards your neck. Some people will describe to us a painful arc where they don't get pain if they're moving their arm lower down, but as they lift their arm up it becomes painful, but as they get closer towards the head it's not as painful. We'll often get pain with overhead activities or placing some demand on the tendons, so lifting, carrying things. Often people get pain when they're lying on that side. The reason for that is tendons tend not to like being squashed or compressed, and when you're lying on that side, the tendon gets pressed against the bone and it can become irritating and painful. It's the same reason why often people get pain when they're reaching across the body. Now, this is by far the most common type of shoulder pain. It accounts for 70 to 80% of all people with shoulder pain in the UK. How long it takes to get better varies from person to person, but we know that most people experience an improvement in their symptoms within a 6 to 12 week period of appropriate management, and that includes advice, modifying the way that we do things, and then trying to build that strength back up and restore the fitness of your tendon. Having said that, we know that the body takes time to adapt, and it might take up to 12 weeks before you start to notice a difference or an improvement in your symptoms with that progressive exercise program, and that's because that's how long it takes sometimes for us to get strength changes. So what are the treatment options for this type of shoulder pain? Well, they're mainly based around trying to restore your shoulder tendon's ability to tolerate the things that it needs to do on a day-to-day basis, so to improve your shoulder tendon's fitness. Now, this often requires reducing the stress that you're placing on your shoulder by modifying the way that we do things, such as trying to put your painful arm into your coat first, stepping towards something as opposed to reaching up for it, or finding a way to just change the things that are painful for you to make them slightly easier. And from there, we need to try and improve your shoulder's strength, and we do this through exercise, but the key here is that we need to make these exercises progressively more challenging and more demanding, so that we're continuing to improve that fitness. The key here is finding the right level of exercise for you, which can be quite challenging, and then trying to be consistent with it and then building it up over time. A lot of people ask us about injections for this type of shoulder pain, and we know that while some people do benefit from a steroid injection, they're not the first line treatment, and the reason for this is most people see a good improvement in their pain without the need for an injection. And whilst injections might help with the pain, they don't address the underlying issue of your shoulder tendon's ability to do the things that we need to do on a day-to-day basis. We also know that particularly repeated injections have a negative effect on tendon health, and what we'll tend to find if you go from one injection to another injection, over time they become less effective. Surgery for this type of shoulder pain has been fairly common in the past, but we now know that it's happening less and less across the UK. And one of the reasons for this is we now don't think it's effective as we used to think it is, and actually research has shown that it's no more effective than physiotherapy or with natural healing over the time. And actually the improvements we see after surgery are now thought to be really related to what happens after you've had surgery, rather than what the surgeon's doing with the knife. And you might be wondering, well, how do we know that? And some people might have seen some of these headlines in and around the press over the last few years, and these headlines came from a big research study that looked at shoulder surgery for this type of shoulder pain. So what they did is they split lots of patients into two groups. Some of them went on to have surgery, so they took them down to theatre, they opened the shoulder joint up, they made the space bigger that we was talking about earlier on, repaired the tendon and cleaned the shoulder joint out, and then sent them on to recovery. The other half of people in this study, they took down to theatre, they put them to sleep, and when they opened the shoulder joint up, they didn't do anything else other than sew them back up, and then they sent them on to recovery. So both groups here had the same recovery, but one group has had shoulder surgery where they've opened the shoulder up and made that space bigger, and the other group have just been cut and sewed back up, so they've not actually done anything to the shoulder joint. And actually the difference between the two groups in terms of pain and the function that you get after that, there is very, very little difference between the two groups. The reason that we think this is actually what happens to people after they've had shoulder surgery. So if we look at that, when you've had shoulder surgery, you'll have some rest, so your tendon will get some time to settle down and recover. And because you've had shoulder surgery, you're then given an exercise program that progressively builds that strength back up and increases your tendon's fitness. So effectively everything that we've just talked about, how we manage tendon pain, people are doing because they've had surgery. Other questions people often ask us is, do I need a scan? In most cases we can tell what's going on just by a good thorough clinical assessment. X-rays, ultrasound scans and MRI scans aren't routinely required for the diagnosis of a stiff or painful shoulder. They might have some utility further down the line in the management, but although scans might give us lots of information, they don't always change how we manage the first part of your treatment. So we've had a scan, it gives us some information, but if we had that information or if we didn't, we're still going to treat this in the same way. We also know that scans don't always give us an explanation for pain, and they don't always give us a reason for your symptoms, so the things that you see on scans are very poorly linked to pain. And you might be wondering, how do we know this? Well, again, we've looked at studies where this data, for example, comes from people with only one-sided shoulder pain, so they've only got pain in the right shoulder, for example, but they've decided to do an MRI scan of both shoulders when the other side didn't have any problems at all. So the orange bar there you can see is the painful shoulder, the green bar is the non-painful shoulder, and up the left is a list of conditions. And actually what you can see is on the scans you can see very similar levels of arthritis in the painful and non-painful shoulders, very similar levels of cysts and rotator cuff problems in the painful shoulder and non-painful shoulder, and very similar levels of cartilage problems of bursitis and rotator cuff tears. One shoulder's painful, one shoulder's not. So what we know from that is just by looking at your scan, we can't always give you an explanation for why you've got pain. So moving on to what we can try and do to help your problem and help your pain. Well, in the first instance, we often have to try and modify the way that we do things, just to try and reduce the stress you're placing on your shoulder joint and the shoulder tendons. This might be something as simple as trying to step towards something as opposed to reaching up for it. Can you put your painful arm into your jacket first as opposed to last? Can you get help lifting really heavy things, for example? If you are repetitively reaching for something in a high cupboard, can you temporarily find a home for it lower down, just until your symptoms settle? If you're doing quite a repetitive job, try and break that into sort of smaller chunks if you can, and try and plan your day so you can space out those activities that are really demanding on your shoulder a little bit more rather than doing them all in one go. In some cases, we do have to rest from those aggravating factors, so just stopping doing them all together, just to reduce the load that you place on your shoulder joint. However, what we should emphasise here is we don't want you to avoid moving your shoulder altogether, so we don't want complete rest, and the reason for this is still moving your shoulder is really important for your joint and tendon health. A lot of people say to us that they have difficulty sleeping, so what we would generally try and say is try and sleep on your non-painful shoulder. People then say to us in clinic, well, habitually I'll roll over in the night and when I land on my painful shoulder it wakes me up, so propping a pillow behind your back might just stop you from doing this. Some people then say, well, that's okay, but then my arm falls across my body and that wakes me up as well, so either propping another pillow underneath your arm that you can rest it on top of, or try and rest it on the outside of your leg might help as well. Using ice or heat can help alleviate your symptoms. We would generally say don't apply it for any more than 10 or 15 minutes at a time, and put it through a protective barrier so you're protecting your skin, because we know that we can get burns from both ice or heat. Now it doesn't really matter which one we use, ice or heat, go with what feels nicer for you. We know there's very little difference between the two. Taking pain relief as you've been advised to and regularly can also help settle your shoulder pain and just allow you to do the things that we need to do on a day-to-day basis, and might help you do the rehabilitative exercises that we'll ask you to do at the end of this presentation. Now, a lot of people here have concerns that they're only masking the pain, or what people then say to us is, I don't like taking tablets. Despite pain or movement restriction, it's highly unlikely that you're going to do any further damage or harm to your shoulder. But what you might find is if you take it regularly, it tends to have a bit of a build-up effect, so you run at a lower level of pain rather than trying to persevere and get to a point where you can't cope anymore or you can't tolerate it any further, and then taking the pain relief and it just taking the edge off of it. And what you'll find, hopefully from there, if you're taking it regularly as you've been advised to, is that you'll be able to do the things that you need to do day to day a little bit more comfortably, and that the exercises will be a bit easier for you to do as well, but which ultimately is what's going to help your shoulder pain. If you're not taking any medication in the first instance, we would say have a chat with a pharmacist if you think you need it, to see what you can take over the counter. If you've done that and that's not been helped, then we always say have a chat with your GP to discuss other options. The reason we say always check with a pharmacist or a GP before you take any medication is because certain medications interact with other medications and other health problems, and they need to make sure it's safe for you to take. The example I usually give here is certain blood pressure medications that we know is a fairly common problem interact with certain anti-inflammatory drugs like ibuprofen, so they need to have that oversight to make sure it's safe for you to take. Other things that can help with shoulder pain are lifestyle factors such as either stopping smoking or reducing the amount you smoke. So whilst people have an understanding of the detrimental effects that smoking has on our health, they're not always aware that it can actually slow your healing down. It has a poor impact on your tendon health and joint health, and actually we know that if you smoke, you're likely to have a longer recovery and higher pain levels than someone that doesn't smoke. So just by reducing or stopping smoking, you might be able to help your pain. Okay. Other things that might help is just trying to lose some weight that might give you some pain relief as well. Now, the reason for this isn't just down to the fact that you're putting less weight through your shoulder joint, because the shoulder joint isn't really a weight-bearing joint, but actually our understanding of how extra body fat works when we're overweight has changed, and we now know that it interacts with your body's other systems, including the inflammatory system. So just by losing weight alone, we know that people get a good reduction in the pain. On the left there, you can see a poster for the UK recommendations for how much physical activity we should each be doing every week. Now, what that looks like is 30 minutes of moderate physical activity 5 days a week. You might be wondering, well, what does moderate physical activity look like? Well, it's something that gets you out of breath, but not so out of breath that you can no longer hold a conversation. Generally, we would say if you don't do any physical activity, try and build something into your weekly routine. It doesn't have to be specific for your shoulder, and preferably something that you enjoy doing, whether it's going for a walk, for example. The reason we say do this is because exercise has lots of other benefits, including releasing your body's internal pain relief systems. We know that everyone's journey with shoulder pain will look slightly different, and it might take a bit of time to start to see an improvement in your symptoms, and it's quite normal for them to vary from day to day basis, and it will be influenced by lots of other factors. What we're looking for here is the longer term picture is, over time, is your shoulder pain getting better rather than that day-to-day change. Try and make small changes and then gradually build them up, and hopefully those small changes can make a big difference for you. And other things that we have to consider is we know that stress, anxiety and depression and lack of sleep can all influence pain and can turn the volume up on pain. And actually try and find a routine that works for you. So if something you feel is helping, carry on doing it. So with this online resource, there are some exercises for people to try with either a painful shoulder or a stiff shoulder. This is just a bit of a guide for exercising with your shoulder pain. Now, we know that everyone's different and some exercises will work for some people whilst others might not. Try and do more of the ones that feel good. And the key to the exercise is try and find a baseline for what you can currently do, and then over time trying to do more. Now, the sets and the repetitions that you see on the resources attached in the exercises are a guideline. People will need to modify them according to their own needs. So for some people it might be they have to start doing less, and for some people they might have to do more. In the very early stages, while your shoulder's quite sore, it's often better to do things little and often in microbursts. But as those exercises get harder, you can start to reduce the frequency of them to allow you more recovery time. So you might go from 2 or 3 times a day, for example, to 3 or 4 times a week. What we would generally try and advise is using a bit of a traffic light system to help guide the intensity of your exercises. So we know that it doesn't really matter if your exercises are painful or not. It doesn't really affect the longer term outcome for your shoulder pain here. But actually we want it to be comfortable for you, and we certainly don't want to wind your symptoms up anymore. So experiencing some pain when you're exercising is completely safe, completely normal, and we're quite happy if that stays between a 0 to 3 out of 10. We're okay if it goes up to a 4 to 5 out of 10 as long as that's manageable for you. But anything more than a 6 out of 10 is probably a bit excessive, and all we're serving to do is probably winding that pain up a bit further. The other thing we need to look at here is actually how quickly do your symptoms settle once you've stopped exercising. So your symptoms should settle sufficiently after doing one set of the exercise to allow you to do a second set of them. But once you've completed the exercises, how do your symptoms respond? So if as soon as you've stopped exercising your pain goes, that's great, we're quite happy with that. If you're finding that your pain's a little bit elevated for a couple of hours but then gradually returns to what's normal for you, then that's fine as long as that's manageable for you. But if you're finding that your pain's staying elevated for the rest of the day, for more than a few hours, if it's lasting into the night or into the next day, then that's clearly too much. We might have overdone it a little bit. So what we need to do there is just take a few days to allow your symptoms to settle, but when you try them again, either don't do so many, try and take one of them out, don't push as hard, try and modify them in a way where you're finding yourself in that green or amber zone. And if you're back in the red zone again, take a few days to let them settle and try and reduce them further. But once you find yourself in this green zone, can we try and push them a little bit harder to make them a little bit more challenging again? So just to sum up, we know that shoulder pain is very common. Despite pain or movement restriction, it's not dangerous to move your arm, and it's highly unlikely to cause any further damage or harm. We know that you might have a stiff shoulder, a painful shoulder. Some people have a combination of the two. We know that most people's shoulder pain will improve with time if it's managed appropriately. In the meantime, we might have to modify the way that we do things and take pain relief as we've been advised to do. And actually, it's usually exercise and rehabilitation that helps settle people's shoulder pain back down. And it's good to try and remain active and try and remain at work if possible whilst we wait for your shoulder pain to improve. If your shoulder pain isn't improving as expected, then please refer yourself online via the website. We've also put together a collection of resources that you can access via the website that include the rehabilitative exercises depending on whether your shoulder pain has a movement restriction to it or whether you've got shoulder pain without movement restriction to it. So the way that we know that is the ones with a shoulder pain and a movement restriction, if you keep your elbow pinned in by your side and you try and take your hand out to your side, that will be really reduced and really restricted. Or you might find it really difficult to get your hand behind your back and you'll really struggle to reach probably higher than your lower back. So for those with shoulder pain with a movement restriction, if you have a look online and use the exercises and the resources for the stiff shoulder, whereas those with the shoulder pain without that movement restriction, so you should really have a good movement in your shoulder. Despite pain, you should still be able to get it above your head, for example, if you have a look at the painful shoulder exercises and the resources there. Again, if you need any further advice or guidance with the exercises, or if your shoulder pain doesn't improve, just refer yourself online. Thank you.